Assalamu alaikum everyone and a very good afternoon. This is Alishma Hamid, co-director of Research and Academics from OSIC. It's an absolute pleasure to welcome you all to today's Journal Club session on a very important and fascinating topic, soft tissue sarcoma from origin to innovation. Let me take a moment to introduce our speaker for today, Hamna Noor, a third-year medical student and member OSIC at KMC. Thank you so much, Hamna, for joining us today. We'll be starting the journal club now. If you guys have any queries, you can drop it in the chat box and our presenter will address them at the end of the session. Thank you so much. Over to you, Hamna.
Okay, I will start my presentation. Bismillahirrahmanirrahim. This is me, Hamna Noor from third year, and today I will talk about a topic that is soft tissue sarcoma. I'll first explain what sarcoma is, how it grows, and what are the different symptoms, preventions, and the different treatment modalities that are used to manage it. I'll also discuss how these treatments have changed over time and what treatment interventions are currently in use. So you can also see the topic on the screen. Now, like why this topic, why sarcoma? So basically this is the month of July and it's sarcoma awareness month. So hopefully you'll have some knowledge about this topic after this presentation. Now, like this soft tissue sarcoma, they are the rarest type of tumors and it account for less than 1% of all the adult malignancies. And it is said that a GP may see only a one sarcoma in their entire career. So it shows that how rare type of tumor it is. Although it is a rare tumor, but still it has a poor prognosis outcome. Now, what is sarcoma? So, before understanding sarcoma, let me tell you about the nomenclature of the tumors. So, basically, there are two types of tumor. One is benign and another is malignant. As we all know, benign tumors are like localized tumor. They don't spread. They are not invasive. They are not metastatic. While malignant tumors are metastatic and they are invasive and they spread to other tissues and other parts of the body. The both benign and malignant tumor can be of mesenchymal origin or epithelial origin. Like for benign, if we see the benign tumors, so for this we use the suffix oma at the end of the type of the cell in which there is tumor, like fibroma, lipoma, chondroma, osteoma. Like if the tumor is in the bone, benign tumor is in the bone, we will call it osteoma. Similarly, for malignant, if it is mesenchymal origin, we use the suffix sarcoma at the end, like fibrosarcoma, liposarcoma, chondrosarcoma. And if it is of epithelial origin, we use the carcinoma at the end, like squamous cell carcinoma. Now, from this slide, you can see that soft tissue sarcoma is of mesenchymal origin and it is a malignant tumor. Now, types of sarcoma. So, basically, there are two main types of sarcoma. One is the bone tumor, and another is which is like called the osteosarcoma, and another is soft tissue tumor, which is basically our today's topic. Now, the classification of soft tissue sarcoma. So, the WHO has recognized more than 100 histological types of these tumors, and they are named according to the tissue they most closely resemble. So, these slides show some of the soft tissue subtypes of the soft tissue sarcoma. Like if it involves the fat tissue, it is called the liposarcoma. If it involves the joint tissue, is called chondrosarcoma. Similarly, for blood vessels, it's called angiosarcoma, rhabdomyosarcoma, and so on. Now, what are the causes? Like basically, what causes these soft tissue sarcoma? So there are basically two main causes. Like one is the genetic disorders, like some hereditary disorders in which there are some gene mutations, and due to these gene mutations, some genes like are overexpressed and some are not expressed, and it can lead to the proliferation of tumor cells. Another is environmental and the epigenetic factors. These are the environmental or some lifestyle influences that don't actually cause the genetic mutation, but they like just alter the gene expression. Like it, these factors can affect how the genes are turned off or turn on or turn off, like how the genes are expressed. They don't change the DNA sequence. Now, what is the mechanism how this tumor grows? First, there is uncontrolled cell growth in connective tissue. Then the number of the cell increases, like they multiply, they divide, and the number increases. This tumor is called now primary tumor. Now, as the number of the cell is increasing, they must need the blood supply for their nutrition. So the blood vessels grows into them, and this process is called angiogenesis. After angiogenesis, some of the tumor cells, they break off from this primary tumor, they go into the circulation and through the blood, they go into other parts of the body, into other tissue. There they settle and they increase in number, and there they form a new tumor which is called the secondary tumor. And this process, like from in which they spread from one part of the body to another, this is called metastasis. Now, some of the genetic mutations, I talked about it in previous slide, that genetic mutation cause soft tissue sarcoma. So here some of the genes are mentioned. Basically, there are some genes which are called tumor suppressor gene. Normally, these genes are activated and it doesn't allow the tumor to grow. But when mutation occur, these tumor suppressor gene become inactivated. The control of the cell cycle is lost, and apoptosis is not like then apoptosis doesn't occur, and the tumor in tumor cells increase in number. Some of the tumor suppressor genes like TP53, RB1, and F1. Another, there's a gene which is called oncogene. Normally, this oncogene is not activated, but when mutations occur, this gene become activated. For example, like MDM2, ALK, etc., and it gives the constant proliferative signals to the tumor, and the tumor grow in cells. One another important mechanism involved in the tumorigenesis is chromosomal translocation. In this process, the segments from two different chromosomes break off and they switch places. This exchange may result in the transfer of gene from one chromosome to another. When parts of two different genes combine during this process, they can form a fusion gene. These fusion genes often encode abnormal proteins that send some faulty signals, such as like continuous proliferation signals, which further promote the development and progression of tumor. Now, like the incidence and geographic variation. The incidence and geographic variation of soft tissue sarcoma show notable differences across different regions. Like in this slide, you can say like the in the developed countries like UK and US, the ratio is comparatively higher than the developing countries like India and Pakistan. This raises an important question, like why is the incidence seemingly lower in regions like in India and Pakistan where one might expect a higher disease burden? So, the possible answer that I found to this question after searching is that in these countries there are limited resources, lack of widespread screening, and there is underreporting of cases. So, the actual incidence might be higher in these countries, but they are not reported, while the developed countries such as the UK and the US have better access to diagnostic tools, well established cancer registries, and routine screening programs, so majority of the cases are reported. Now, what are the risk factors? The genetic mutation, I discussed it in detail in the previous slides, that it can increase the risk of soft tissue sarcoma. Other epigenetic factors like exposure to radiation, the chemical exposure, and certain medical conditions. Some of the disorders, inherited disorders that increase the risk of soft tissue sarcoma, like in Leaf-Romani syndrome, there is a mutation in the gene TP53, which is a tumor suppressor gene. So if this gene is not present in this gene, when these genes are present, it increases the risk of soft tissue sarcoma. Then another, like what are the Gaussian disease, in which there is a mutation of soft tissue sarcoma. Now the symptoms. So it a new lump or swelling, a severe stomach pain, stiffness in the joint. Now the treatment. There are mainly time, that is surgery, radiation therapy, and chemotherapy. So treatment options depend, like which we will choose which treatment. It depends on certain factors like the type of sarcoma, the grade, the stage of sarcoma, the location of the tumor, and the age and health of the patient, and also whether the cancer is newly diagnosed or has recurred. Now, here are mentioned some of the stages of the soft tissue sarcoma. Like if the size of the tumor is less than or equal to 5 centimeter, it is a low grade and it's called stage 1A. Similarly, in stage 1B, the size of the tumor is greater than 5 centimeter, it's also a low grade. Similarly, stage 2, stage 3A, stage 3B, and stage 4. Now, the treatment options. So it depends on the stage. Like if the patient comes, we will first screen for the stage, like in which stage the tumor of the patient is, and then we will treat accordingly. Like stage 1 typically managed with surgery, including techniques like Mohs microsurgery or wide local excision. I will explain these surgical options in detail in the next slide. Radiation therapy may also be used in some cases. In stage 2 and 3, they are usually treated with a combination of surgery, radiation therapy, and chemotherapy. Similarly, stage 4 managed with chemotherapy, including the targeted therapy. And recurrent sarcoma, treatment options vary and may include any or all of the above depending on the individual case. So, all the treatment strategies are summarized in this slide. Now, Mohs micrographic surgery. So, in this surgery, the tumor is cut from the skin in thin layers. Then, each layer is examined for the cancer cells and viewed under a microscope. And then, layers continue to be removed until no more cancer cells are seen. So, in this type of surgery, the surgeons try their best to remove as little as normal tissue as possible. Now, another wide local excision surgery in which tumor is removed along with some normal tissue. In limb sparing surgery, tumor is removed in an arm or leg, but they are not amputated. In amputation, the arm or leg is amputated, and in lymphadenopathy, the lymph nodes are removed. Now, the target therapies. This is the most important part of my presentation, the targeted therapies. So far, I have discussed chemotherapy, radiation, and surgical treatment, but these often come with significant side effects. In contrast, the target therapies are designed to attack only the cancer cells, thereby reducing damage to normal tissue, and they minimize the side effects. Now, our first targeted therapy is anti-RK targeting. So, what is anti-RK? It's basically a fusion gene, as I discussed in previous slides about the fusion gene, that it codes for abnormal protein, and then it codes for abnormal that cells, and it allow the cells to grow uncontrollably. So there are certain drugs which target this anti-RK, like larotrectinib and entrectinib, and these drugs are approved by the FDA. Now, there is EZH2 inhibitor. It's specifically used in epithelial sarcoma because in this sarcoma there is a loss of protective gene called INI1. When this gene is lost, this protective gene, the EZH2 become overactive and it helps the cancers to grow. So we have to inhibit the EZH2. For this, the EZH2 inhibitor drug that is used is tazometostate. It is also an FDA approved drug. Now, there is MDM2 inhibitors which is used in liposarcoma. In liposarcoma, there is excessive MDM2 which turn off the tumor suppressor gene, that is P53. So the drug which is used to inhibit MDM2 is this is a big name mentioned here, BI 907828. This drug is not FDA approved, but still in testing, it shows some hopefully and some good results. Now, another there is gamma secretase inhibitors. It's used in desmoid tumors. Desmoid tumors are actually not the cancers, but they behave like it because they originate. They have the same origin as soft tissue sarcoma, that is the connective tissue. So what happened is this: in this type of tumors, there is excessive gamma secretase which activate the notch protein, and that help these tumors to grow. So so there should be drug which inhibit that gamma secretase, so that notch protein is not activated and tumor doesn't grow. So that drug is nirogacestate. It is also FDA approved drug, but it have some side effects, like it may affect the ovaries. So we should be careful to use in young women. Another is CDK9, which is a new hope in soft tissue sarcoma. Like in soft tissue sarcoma, there is overexpression of CDK9, and it helps the cancer cells to grow by making proteins. So our goal is to inhibit that CDK9. So there is a drug name is KB0742, but this drug is not still FDA approved, and still trials are ongoing, like phase 1 and phase 2 trials. But when they are tested in STS, the soft tissue sarcoma patients, and it shows some good results. Another is hippo pathway. What is hippo pathway? Basically, it's a pathway like which maintain homeostasis. It doesn't allow the tumors to grow. It doesn't allow the abnormal growth, the abnormal proliferation of the tumor. But what happened in epithelioid hemangioendothelioma? There is a fusion gene, and these fusion genes cause the overactivity of the TAS, which cause uncontrolled growth. So, what is our goal? Our goal is to inhibit the function of this fusion gene and inhibit the TAS. For this, we can block the TET transcription factor, which is needed by the TAS to work. Now, still there's some phase 1 trials are ongoing which are exploring the possible inhibitors of this TET. Like still the trials are going on, and hopefully we will see some new emerging drugs that will inhibit the stress transcription factor, and epithelioid hemangioendothelioma could be treated. Now, how we can diagnose the sarcoma. So it can be diagnosed by biopsy, the blood test, some imaging techniques like MRI and CT scan. So what are the prevention? Avoid exposure to radiation, stay away from smoking and alcohol consumption, get your self screen if anyone in your family had soft tissue sarcoma, avoid coming in contact with certain chemicals. Now, what's the situation in Pakistan? Like I discussed about the incidence in the previous slide, but here it mentioned in both male and female. Like in male, it's 3.3 per 1 lakh per year, and in female, it's 2.1 per 1 lakh per year. Now, the average age at diagnosis is in both gender is 41. And what's alarming? The alarming is this, that approximately 60% present at the stage 2 and 4. Like when they go to the hospital and when they screen themselves, they are already at the higher stage. And as we know, the higher the stage, the harder it is to treat any type of tumor. So, what are the barriers to this? As I discussed, it is late stage diagnosis, the financial constraint, and few specialized sarcoma centers. Like majority of the people, they live in distance areas like village, in which there are no specialized sarcoma centers, and they are not financially stable to travel to the cities or travel to these areas for screening. So often when they present to the hospital, they are already at the higher stage. Now, the most advanced and groundbreaking development in cancer treatment is the emergence of precision medicines, and particularly in soft tissue sarcoma, it's development of a tool called QPOP. So QPOP stands for Quadratic Phenotypic Optimization Platform. So what is this QPOP? It is recently developed by the scientists, And it worked by testing a patient own tumor cells in the lab. It tries out various drug combinations and identify the most effective personalized treatment, all just within like 7 days. Within 7 days you will know what possible treatment should be used in this specific patient. Like in this study, the study which was performed recently, the researchers collected tumor samples from 45 patients with soft tissue sarcoma, and they used this QPOP system to test 12 different cancer drugs and also tried out 155 different combination of each drug. And it has been successful in around 70% of the cases, accurately predicting which treatment would work best. Like it also discovered a new combo AZD5153 plus pazopanib that inhibit the MYC gene, and it worked better than other standard treatment. Now, why QPOP is innovative? Like why we are talking about it? Like what's why it's new? So every human is like different, not just in how we look or live, but also in how our bodies respond to disease. This is especially true in cancer. Like two people may have the same type of cancer, but the way it develops in their body, the underlying biology, and even the way it reacts to treatment can be completely different. So, how can we expect the same drug to work equally well for every patient? So, that's the limitation of traditional treatment approaches like the treatment I discussed, the surgery, the radiation therapy, and the chemotherapy, and then the targeted therapies as well. But QPOP, it doesn't guess based it doesn't guess based on the past data like the clinical trials that are available. It doesn't rely on that. Instead it tests each patient's own live tumor cells in the lab to see exactly which drugs would work better for them. And like in other treatments, like in targeted therapies I discussed, we need to know about the mutations and what genes are involved, and then we give inhibitors according to it. But here we do not need to know the mutations. It directly gives us the correct combination of drug. So, and it is especially valuable for rare cancers like soft tissue sarcoma, because already the clinical trials and the researches that are present on these rare tumors, they are limited. So we, with the help of QPOP, it's the most current and promising advancement in the treatment of soft tissue sarcoma. And with that, I want to conclude my presentation. If you have any questions, you can ask.
Thank you so very much, Hamna, for that informative and incredibly insightful presentation. That was really amazing. And I hope everyone has learned something valuable today. It's the time for Q&A session. So if any one of you has any query, please either unmute yourself or drop in the chat box. Okay, so we have a question from Muhammad Uzair. Is tumor genesis related to expression of heterochromatin? As you mentioned that oncogenes are normally inactive, just like heterochromatin, which is also normally transcriptionally inactive.
Also, guys, if there's anything that anyone would like to add, or like even if it's not strictly related to the presentation, if there's a question that somebody else can answer, we can all like sort of pool in our knowledge together and discuss from there on. So from what I know about the question that was there asked, he mentioned that tumor genesis is related to heterochromatin or not, considering heterochromatin is usually inactive. So from what I know is that there is a connection between the two, but it's not as simple as we think it might be, considering oncogenes, as you mentioned, they're usually silent or tightly regulated, right? But sometimes when there is a cancer, so what happens is you can have chromatin remodeling, where certain promoters or enhancers, they can switch from a silent heterochromatic stage to a chromatic stage to a euchromatic active state. So tumorigenesis usually involves converting repressed or heterochromatic like loci into active ones later on. So it's not like a certain gene will stay heterochromatic forever, if that makes sense. Sometimes you lose heterochromatin when there's like repeats or chromosomal instability or aneuploidy or any sort of damage to the DNA that can cause a silent gene to sort of become activated, just like how an activated gene can be silenced. I hope it answers your question. But if there's anything that anybody else can add, we can obviously discuss.
Thank you, Zainaba, for clarifying. That actually makes sense.
Was there the second question? Answering your second question, there, you're right. Radiation therapy does increase risk for cancer later on. There is a latency period, so you won't see another cancer sprout up for another 5 to 10 years. You'll see it way later down the line. However, I mean, there's obviously risk factors that increase the likelihood if you're, exposed at a younger age, or if there's like a larger treatment field. Say you have a big cancer that you're treating with radiotherapy, so that is, or a higher dose, for instance, that is going to increase the likelihood for a cancer sprouting up later. Or if you're doing like concurrent chemotherapy with radiotherapy, that is going to obviously predispose you to cancer. If you already have like genetic conditions or mutations from before, you can increase the likelihood of cancer. However, there are newer oncology techniques that radio oncology techniques that minimize this risk. So there's precision techniques where you target like very specific areas of your body that require that radiotherapy. It's one of them we actually discussed in our what is it called, in our design sprint that we did a few months ago. It's called a stereotatic radiosurgery, where you target very specific parts of your body and ensure that very limited parts of your normal tissues are exposed to radiation. There's also like lower radiation doses that you can use, or you can avoid radiation altogether if surgery or chemotherapy suffice, especially with kids. And you can also like make sure that you're checking on patients who've been exposed to radiotherapy, especially with breast cancer and lymphomas. Because we many a time you do apply radiation on the chest wall and the pelvis and the brain and the spine, so there's obviously chances for possible secondary cancers to sprout later on.
Okay, so this brings us to the end of our Gen Club session. I would like to thank all the participants for making the session kind of interactive as well. And thank you so much, Hamna, for your incredible presentation. It was really informative. Thank you so much, everyone. Allah Hafiz.
Also, sorry, there's another question that I found really interesting. It's in the chat box. Somebody asked if why soft tissue sarcomas are rare comparatively. So from what I know, it's because so again, when you're looking at tissue origins in cancer, you know that tissues that rapidly divide or divide more often, there is a higher chance for a mutation to occur because they're dividing so rapidly all the time. So there is like for you to sort of get a mistake, and that sort of picks up and turns into a cancer. But the thing is, soft tissue sarcoma, its origin is of it's of mesenchymal origin, and mesenchymal cells, or cells that create your connective tissue, they don't divide as rapidly as say epithelial cells do. So which is probably why you see more breast, colon, lung cancers, because cells of their origin, they divide more all the time as compared to mesenchymal cells, which divide far less frequently. Also, there can be another reason why, because there's very few surveillance options for like soft tissue sarcomas, for instance. Like I was just searching up articles right now, and I realized that there's a huge research gap as well. The last epidemiological study from Pakistan was, I think, in 2008 or 7. Like they published a study with data from the 90s to the early 2000s, and the last epidemiological study that I could find was from a cancer center in Karachi. It's not even countrywide, I think, and it was from like early 2000s. So we don't even have data that we can sort of quote from say the last 5 years. So that could also possibly be a reason why we don't have, because we don't have enough surveillance on it, and hence we have lesser numbers to report eventually. I think we're done. Thank you so much, everyone who joined us. I hope this session had something to teach you guys, and we hope that we can give you more sessions like these on a regular basis, inshallah.
So, okay, I will share the links of the papers of the articles from which I have made this PPT. From where you can read like more in detail about this soft tissue sarcoma.